This is the second part of your lecture. This is gastrointestinal systems dealing with pediatric disorders. My name again is Molly Lombardi, and if you have any questions, please feel free to email me or stop in my office at any time. This content is going to focus on cleft lip and palate, the nutritional needs, post-operative care, and nursing care plans for clients with either cleft lip, palate, or both. Pyloric stenosis, the nursing assessment and care plans associated with those. And finally, intussusception, again, the assessment and care plan for patients and clients with intussusception. Cleft lip, cleft palate, and cleft lip and palate. By saying that, I need to imply that a baby can be born with any combination. They may have either a cleft lip, cleft palate, or both. Also, you can see on the image that they can have a unilateral cleft on one side or a bilateral cleft on both sides. These are abnormal openings, and they're more commonly there's the most common congenital cranial facial deformity seen. While the exact cause is still unknown, we do know that there are genetic components and also environmental components such as smoking during pregnancy. Babies born with this defect may also have other birth defects. The diagnosis is made based on observation at birth, and it's managed with surgical repair. While it's diagnosed at birth, the surgery usually doesn't happen until about 6 months to 2 years of age. And then after, the child will be subject to speech and OT therapy. They may need orthodontal and cosmetic surgery as a follow-up when they're a bit older. The problems commonly seen with someone with either cleft lip, palate, or both are with dentition. So again, the orthodontic work may need to be done. And more frequently, they have issues with otitis media or ear infection, hearing loss, and speech dysfunction. Feedings can be a challenge with infants born with either cleft lip, palate, or both. If the cleft is rather small, sometimes breastfeeding may be possible, but usually the mother will have to pump the breast milk out and feed with a special bottle and nipple. Typically, the milk or formula will be placed into a bottle with a special nipple that's often soft and compressible, with often a longer nipple so that way it'll bypass some of the cleft lip and cleft palate. While most of the cases of cleft palate are identified at birth, sometimes they're missed, but identified during the first feeding because milk will come up through the infant's nose. So because there's a hole, the infant is not going to be able to make a strong suction, and therefore the bottles only require a little bit of manipulation to release the feedings. The first image on your screen on the left is a squeeze bottle or a compressible bottle that allows the caregiver to gently compress the bottle against their fingers there, and it releases a small amount of milk. The image in the middle, this is called a Haberman nipple, which is currently the most commonly used method for infants with cleft lip and palates. If you click on the image, it's going to send you to a short video that explains how the nipple allows for easy feedings, not just for infants with clefts, but for other issues as well. Another way to provide nutrition is through a syringe with a rubber tip. And then the last image is of a bottle that allows for upright positional feeding, and this will avoid risk of aspiration for those with large cleft palates. It's also important to recognize that the infants are going to need frequent burping, and this is no surprise since the cleft allows for air to enter during the feedings, and they're more likely to swallow excess air. After surgical repair, there are important nursing interventions to keep in mind. The first one, the infants are likely going to come up after surgery with elbow restraints that are called no-nos. They are soft but stiff restraints that stop the infant from touching their face where the surgery was just done. And this is necessary to prevent the infant from contaminating the site, which can lead to infection, and also to prevent injury to the newly operated site. Like any restraint, our job as nurses is to assess the extremity every 30 minutes for circulation and at every 2 hours to remove the restraint one at a time to assess the skin underneath and allow for guided movement or activity and range of motion for about 10 to 15 minutes, all while making sure you're protecting the sutures. For sleeping, there's some conflicting research and recommendations right now for infant positioning with cleft lip and cleft palate. The general objective is to prevent aspiration, which some sources recommend placing the infant in an inclined sleeper, such as an infant seat, while others recommend placing the infant in a supine position to allow for drainage. And then some do say on their backs to sleep, just slightly inclined. So each facility will have their own policy, which are likely to change based on the current research. You want to assess and manage pain. And for the infant to early toddler area, this can be a little bit hard. You have to base your pain management on nonverbal cues and also rely on the parents because they know the infant better than we ever will. So asking them if they feel their child is in pain is a good way as well. You want to make sure not to use or allow parents to use straws, pacifiers, spoons, oral thermometers, or toothbrushes, and this is all to protect the sutures inside. You also want to provide emotional support for the parents because this is an extremely stressful time and requires a lot more management and care. You're going to make sure there are referrals for speech therapy and for an orthodontist. You also want to make sure that there are follow-up appointments already scheduled with an ears, nose, and throat specialist. In addition, there's also a referral that should be made to the American Cleft Palate Foundation for support if one hasn't already been done pre-op. The nursing care plans. So on your objectives page, one of your nursing care diagnoses that you have is impaired skin integrity. So in this case, I might relate it to the surgical repair of the cleft lip or palate, and the as evidenced by would be the surgical incision. Our outcomes would be to have healing of the surgical incision, and this would be as evidenced by the granulation tissue, maybe at a 1 week post-operative appointment. And also to have no infection, and we would be seeing this through a fever. So we might say client will remain afebrile during hospitalization. So the way we get there, or our nursing interventions, these are going to include careful cleaning of the incision site and teaching parents how to clean the lip incision or palate after feedings, and this is all as directed by the healthcare provider. Also to apply antibiotic ointment as ordered. To observe for signs of infection, which you guys know what they are, but you want to make sure the parents are educated on the signs of infection, which include the redness, swelling, exudate, and also to educate the parents of when to call their healthcare provider for certain symptoms. We want to educate parents on the importance of preventing crying, and this is to help avoid sutures from popping, and also frequent crying and stress will delay healing time. So we'll be teaching the parents the importance of holding and cuddling and also medications as needed, such as Tylenol. For the evaluation of the care plan, it will simply be if the outcomes were met. So is the incision site healing? Do we see granulation tissue? And is the client free from signs of infection such as fever? The next pediatric GI disorder that we will talk about is hypertrophic pyloric stenosis, or commonly simply called pyloric stenosis. What this is, it is a narrowing of the pyloric muscle sphincter, which you can see in the image on the slide. It's at the bottom of the stomach, and it's the most common surgical disorder of early infancy. The cause for this is still unknown, but it may be hereditary, and also it may be more common with other GI disorders. And for some reason, it tends to be more common with male babies. The manifestations are progressives. It's progressively leading up to projectile vomiting in a previously healthy infant. So the newborn will go home and be tolerating feedings just fine for weeks, and then they'll start to throw up after feedings. And then this will turn into projectile vomiting, where it actually shoots across the room. When you're assessing the abdomen, you will see, you might see peristaltic waves that go from the left to the right before vomiting. You could also sometimes palpate a movable olive-shaped mass in the right upper quadrant. You'll also assess the baby to be irritable and hungry shortly after being fed. And this makes sense because they're still hungry. They're not tolerating any other feeds. Everything's coming back up. So this condition typically results in dehydration and metabolic alkalosis, as well as impaired nutrition. So it is important in regards to diagnosis to do a comprehensive physical assessment of the symptoms that we just went over. The ultimate diagnosis is usually done with an abdominal ultrasound or an upper GI barium swallow. And just like we talked about in the first PowerPoint, they have to swallow this, and usually you'll put it right in their bottle. They'll swallow it down, and then they'll go down for a series of x-rays where they'll see the contrast go in the stomach, and then a small area where it doesn't go through, the sphincter, the pyloric stenosis, and it'll come right back up through the esophagus. The repair is surgical, and it's usually done laparoscopically. They will open up the pyloric stenosis, the enlarged stenosis, so they'll make that dilated again and opened. But before they can go down for surgery, they're usually dehydrated and have electrolyte imbalances that need to be corrected. So they will correct those two things through IV fluid and IV electrolyte replacements. And this is commonly seen with especially potassium. When assessing the infants, the first thing you want to do is get a history, and that's going to be from the parents. You want to ask questions such as, what are the feeding schedules like, and how have they evolved? For vomiting, you want to know how much, what color, the consistency, if it's associated with feedings. With pyloric stenosis, it's often large amounts that are the color and consistency of the feedings. Look in your text that I highlighted on your slide for the vomiting chart for more information. You also want to find out if there's evidence of dehydration, and you're going to do this through your assessment findings. So you'll see an infant that's dehydrated will have the absence of tears, depressed fontanelles, poor skin turgor, dry mucous membranes. They'll have a reduced amount of urination, and also the urine will be dark and have a higher odor than normal. You can also look at the serum electrolytes if they're ordered, also called a metabolic panel, to assess for the electrolyte imbalances that are common. The abdominal assessment, you may have assessed for an olive-shaped mass that's sometimes present. We talked about this in the slide before. And also the wave, the peristaltic wave, just prior to emesis could be present as well. The family assessment, you want to see how they're coping. Parents who come in with an infant with pyloric stenosis are often extremely stressed out and sleep deprived. Remember that the infant's been irritable and only consoled shortly after feedings and return right back to crying and being hungry. So often the parents feel guilty or incompetent. They're not able to care for their child or make them happy with feedings. So you want to pay attention to how they're doing as well. The image here on this slide is actually a link to a video, and it goes over not just pyloric stenosis, but also the repair of pyloric stenosis, the pyelomerotomy. And this, again, it's a good idea to understand this, have a general understanding, because you're going to be providing patients and their families with education, both pre-op and post-op. So you'll have to have an understanding of what they're doing and why this is happening to their newborn. For the nursing diagnosis, your book suggests a few here. Note that the third one is bolded, impaired skin integrity. This is the one that happens to be on your objectives page. So we want to see healing, dry, intact incisions from the surgery. But don't forget about deficient fluid volume, which could indicate dehydration. This is the first one listed on your page. In particular, look at the urine output here. A baby should have urine output greater than 2 to 3 milliliters per kilogram per hour. So that's how we would evaluate if they were being successfully rehydrated, by assessing the amount of urine. The next diagnosis is imbalanced nutrition, less than body requirements. So are they vomiting and unable to maintain their birth weight? So a goal would be for them to tolerate feedings without vomiting and increase their weight as they should according to the normal growth chart. So that's how we can evaluate the effectiveness of the surgery and the care of this client. Again, that last diagnosis that's bolded, we already went over in the other section under the cleft lip and cleft palate. So it's so similar, we don't need to go over it again, but I did include it here. Nursing interventions for both pre-op and post-op. So let's start with the pre-op interventions. The first one there is NPO, or nothing by mouth. The infant will remain NPO, and as you can imagine, even though they're not tolerating feeds, they don't have the comfort that they get for that short amount of time, and this can lead to a great deal of crying. So the infant has to be soothed and rocked and swaddled 24 hours a day. So a lot of times the infants are at the nurse's station with the nurses during the nighttime so the parents can get some much needed rest. As I said earlier, before surgery, the IV hydration and electrolyte imbalances must be completed before they're stable enough for surgery. So as the nurse, you're going to be responsible for obtaining IV access and monitoring the IV site frequently. The infants aren't able to tell you if there's pain associated with an infiltration at the IV site, so this is why it's important for pediatric nurses to constantly assess IV sites. Vital signs, of course, just like any other patient. Daily weights and strict intake and output. This is going to give us good information about how their rehydration status is going. You want to keep them warm and kind of decrease the stimulation, keep them happy again. And this is to reduce the metabolic rate. They are already deficient in their nutrition, so we want to conserve as much energy as possible. So we wouldn't want them to be upset and crying and cold, which would all increase metabolic rate. Oral care should be done, a little bit extra attention on this because their mucous membranes are very dry from being dehydrated. Making sure the head of the bed is elevated and also having suction set up to prevent aspiration when they do vomit. So you want to make sure those safety things are all taken care of ahead of time. Parental teaching. So this has to do with the video that you saw a couple slides ago, being able to walk them through the procedure and what to expect. So let's go on to the post-op care. So you're going to be assessing for bowel sounds right after surgery, and they're usually present pretty closely after a few hours after surgery. They bounce back pretty quick. And once there's bowel sounds present, feedings can be initiated. These usually start with electrolyte solutions such as Pedialyte, and it's usually small amounts, about 1 to 2 ounces initially per feed, and they slowly increase as directed by the healthcare provider to a full formula or breast milk feeding. Once the infant is tolerating the feedings, the IV fluid should be discontinued to prevent fluid overload. And the routine post-op care for anyone, so that would be the vital signs, assessing lab values, assessing the incision site for signs of infection, and then again, parental teaching. Keep them informed about what to expect and symptoms that you would need to contact a healthcare provider for. Now we're going to go on to intussusception, which is the last pediatric condition we're going to discuss in this lecture. This is when a section of the ileum telescopes into the ascending colon. This usually happens in children before the age of 2, and it's more frequent in boys than in girls. The cause is unknown, and it sometimes is predisposed by an upper respiratory tract infection or a viral infection. And it's also associated with dehydration. So the reason this is a medical emergency is because it's part of the intestine. When it telescopes in on itself, it doesn't get adequate blood supply and necrosis starts to occur. So without treatment, sepsis will take place and lead to shock. It's usually diagnosed through an ultrasound. You can see the image on the top right looks like a donut, and this is the ileum in the ascending colon in a cross-cut view. The management is to restore the bowel to its position as soon as possible. So the first line of treatment is to have an air or a barium enema, where the goal is to have enough pressure in the colon that it pushes the bowels back up to their original position. This is a painful procedure, and it's not done under anesthesia. If this procedure is unsuccessful or it doesn't stay where it's supposed to, so it can correct itself, but then after a few hours it might go back to being intussuscepted, that's when surgical repair is needed. First, that they're going to do a laparoscopic procedure, and then the last resort is to do an open surgical procedure, which you can see on the bottom picture, where the physician is actually taking the intestine and pulling out the part that went inside. Here are some considerations for nursing assessments with a client suspected of intussusception. The health history, you want to find out if they're a previously healthy infant, and you also want to know if they just recently had a viral infection like we talked about in the last slide. You want to ask about their pain and assess their kind of pain. Usually it'll be a progressive symptom of pain, so it'll get worse with time. The most common symptom of intussusception is this intermittent abdominal pain, where the child will curl up in a ball or draw their knees to their chest and scream in pain. It's quite awful to watch, and often the parents are extremely upset during this, as to be expected. The pain is in waves because it gets worse with peristalsis. Sometimes there's vomiting and nausea, and it's usually associated with the extreme pain. Abdominal distension can be present. A hallmark is the palpable abdominal mass that's in the shape of a sausage, which is the ileum folded into the colon. You can see it on the bottom black and white picture of this slide. You want to assess the bowel sounds. Are they hyper or hypoactive? You want to assess the stools. Frequently, you will see this current jelly stool, which is almost a dark red mucousy diarrhea stool seen in the picture on the top of the slide. This is another classic hallmark sign of intussusception. With intussusception, you need to be monitoring for signs of sepsis and also an infection in the lining of the stomach. This is a very serious and grave condition. What we would see is a fever, tachycardia or increased heart rate, change in blood pressure, usually it drops down low, change in level of consciousness, usually it's almost sedated like, and respiratory distress. As you can imagine, these are very serious symptoms that need to be taken into an operating room immediately if these are seen. Here's a summary of common nursing interventions, both pre-op and post-op. So remember, there's a wide range of interventions that may be used to resolve this, from an air enema to an actual open procedure that could include removing necrotic bowel part and having a bowel resection. So we'll do the pre-op here. So you're going to assess for signs of dehydration, shock, or sepsis. The patient may have IV fluids, and you can also be doing pain medication, although it's hard because by the time you have a patient who's having an episode, by the time you draw up the medication, which is frequently morphine, and administer it, the episode is over, because remember, it's intermittent abdominal pain. And then while they don't have full sedation for an air enema or a barium enema, they might have some light medications such as Ativan to help relax them during it. For post-op, it's a wide range. If they had a full operation, it would usually be NPO until the bowel functions return. They could have an NG tube, especially if it was a bowel resection, and that would usually be to intermittent suction for decompression. There's usually IV fluids in those cases, pain medication, and then as they start to have bowels return, they would be on a clear liquid diet and advance as tolerated very slowly. And again, this really varies depending on what kind of correction they needed. For all of the cases, you want to assess for reoccurrence. Hydration is a key for some reason to prevent reoccurrence, but you need to be on the lookout the whole time to see if this happens again. You want to meet their developmental needs, so making sure your nursing interventions are appropriate to their developmental age, not their numeric age. And then parental teaching for discharge, making sure they know the symptoms and when to return. It's also common to have that current jelly stool again after it is repaired. One time is usually okay, but it shouldn't keep recurring after that. So you would want to educate them on what is normal and what is abnormal. So this concludes this part of the voiceover, and go on to the third voiceover, and I'll meet you there.